So this is a slide which, it really caught my attention. Everything is on fire and everything is wet and everything is cold. So this is how a lady feels when she's going through this terrible period. So there are a lot of climacteric symptoms that take place when a lady enters menopause, but we are interested here in the vasomotor symptoms, the hot flashes, and the night sweats. So coming to the epidemiology in a few words, the vasomotor symptoms or the hot flashes or night sweats are most frequent menopausal symptoms a lady experiences. In the Asian population, hot flashes are to the tune of 42.4%, night sweats to the tune of 34.8%, and sweating to the tune of 29.7%. In US population, it is approximately 80% of the population that gets affected. Now, symptoms become far more common during the menopausal transition, with a frequency of approximately 40% in the early transition and increasing to 60 to 80% in the late menopausal transition and early post-menopausal phase. These are Indian data that is collected, very proud of the Indian research that was done. And according to the last one done by Mita in 2012, it was the Indian population is affected to the tune of 70%. So average daily number of hot flashes that take place according to the severity are, the very severe ones are to the tune of 4.1, severe ones are to the tune of 5.7, moderate to the tune of 5, mild to the tune of 2.5, and the duration of hot flashes can be anything between 1 to 5 minutes and can last for as much as 15 minutes, which is a very long time. The ranges are from transient feeling of warmth to sudden heat wave over the whole of the face and body, and this reddening of the skin and sweating. So what is the epidemiology of these hot flashes? 20% of women who experience severe hot flashes seek treatment. Occurrence of vasomotor symptoms starts in the premenopausal period, and 10% of women experience vasomotor symptoms even 10 years after menopause. So what the basic the problem that takes place is the fluctuation of the estrogen level. You see how the estrogen level fluctuates in the perimenopause and the hot flashes start. And as the estrogen dips, the hot flashes become more and more severe. So what happens during a hot flash? The thermoregulatory mechanism is actually is what that is affected. There is a narrowing of the thermoregulatory zone. On the left slide, you see there is a thermoregulatory zone here. So this is the normal thermoregulatory zone. If the temperature goes above this, you have a high degree temperature. If it goes below this, there is hypothermia. So there is a narrowing of this zone which takes place during when the estrogen starts declining, and so the temperature will very easily cross the upper level and the lower level, and that is how you get the hot flash and the cold sweat. This is how the lady is. The lady sleeping next to this gentleman is all on fire, and she doesn't know what to do while he's having a comfortable night's sleep. So what is the frequency and severity? There can be even 4 to 5 hot flashes in a day on an average, or can be as high as 20 in a day. 1 in 4 women report having hot flashes daily. Daytime hot flashes are reported more than night sweats, and post-menopause VMS occur in as many as 3 out of 4 women in the first 2 years post the final menopausal period, and decline slowly afterwards, taking 8 to 10 years, which is a long time, to return to the pre-FMP levels. Now, what are the risk factors associated with VMS? There is good evidence that menopausal status, of course, it is very important. Anxiety or depression prior to menopause, these females are more prone to having vasomotor symptoms. Obesity, now this is a paradox here, because if you are obese, the fat itself is a precursor of estrogen, but obese patients tend to have more vasomotor symptoms. Black race, that is the ethnicity involved. Smoking, both active and passive smoking. There is mixed or no evidence for physical activity, diet, and alcohol consumption. Now, coming to the management part, what are the general principles we have to follow when we think of management? Symptom intensity and frequency has to be kept in account. Medical history of the patient, personal choice of the patient, coexistence of other menopausal symptoms such as depression, as these women often require treatment with both MHT and antidepressants. Now, these are the recommendations. This slide actually is a very nice slide, but can be read only on the the large screen. But the gist says that when a woman comes to you with hot flash, what do? You assess the symptoms, the duration, the severity. precipitating factors, prior interventions, comorbid conditions, concomitant medications if she's taking any. The mild ones, if she has mild symptoms, then there's just a feeling of warmth and is barely noticeable by her. Then moderate can be hot flashes, which are very apparent and with some perspiration, but they're not interfering in her daily day-to-day work. Severe ones are intense hot flashes, which interfere in her daily work. So for the interventions, lifestyle changes, very important for all the three patients. Non-prescription remedy, for example, isoflavones, black cohosh, vitamin D can be taken for the mild cases. Systemic estrogen containing treatment remaining the gold standard. Estrogen is the gold standard treatment because that is the problem, from where the whole problem starts, is the dipping estrogen level. So the gold standard for women with moderate to severe symptoms and without contraindication, the lowest effective estrogen dose should be used for the shortest period of time. Women who cannot or may not take estrogen containing treatment, then all the other non-MHT drugs can be kept into account. And there should be a continuous assessment of the patient, evaluate the treatment and the necessity of the treatment all along, especially use of estrogen containing treatment or other treatment, pharmacological treatment. There should be annual assessment of the patients regularly. So coming to step-by-step management of menopausal hot flashes, assess the severity of the hot flashes. So if she's having mild symptoms, you first go in for the behavioral therapy, that she should be wearing heat-friendly clothing, use of fans to lower the room temperature, avoiding triggers, for example, too much of alcohol or spicy food. Coming to the moderate to severe hot flashes, those which are interfering with the activities of daily living. MHT is the gold standard of treatment. Oral or transdermal according to your choice, estrogen with or without micronized progesterone depending upon uterine status, OCPs depending on the period at which the hot flashes are occurring, then CE plus basodoxifene, not available here, but a very, very nice combination available in the US. Depending upon the patient's preference and profile, start with the lowest possible dose and adjust the dose as per response to treatment and or the side effect profile. If there is a good response, consider gradual taper after 1 to 2 years. If there is a recurrence, consider reintroduction of MHT. If there is moderate to severe but predominantly nocturnal effect, then you start gabapentin, which is a drug of choice for nocturnal hot flashes or night sweating. If good response, continue. If poor response, you can switch to MHT anytime. MHT, if contraindicated or if patient is not willing, then you start with SSRIs or SNRIs. If no or poor response with these drugs, then you go to another the drug of the same class of drugs. But still, if no response, then you can go on to MHT. So these are the severe hot flashes when it interferes in a daily job or daily work profile. Now, when you're prescribing MHT, what are the points to be kept into account? Identify the goal of your treatment, rule out contraindications, perform the risk-benefit analysis, discuss with the patient. Start early rather than late. Very important that you have to start in time. Prescribe the lowest dose required, evaluate the response, can continue for 3 to 5 years, individualize the dose and the duration. No mandatory time limit is there. Follow up the patient annually. So women with mild flushes, we have already said that behavioral changes are to be instituted in time for these patients. And other points to be kept in mind are that other complementary, alternative therapies can also be taken into account. Most of these have limited evidence of efficacy, but they benefit from the placebo effects of these therapies. And at times, the benefit can be really substantial. Now, coming to when you think of pharmacotherapy, that is the MHT, for most women with moderate to severe hot flashes and no contraindications, MHT is the treatment of choice. For women interested in MHT, the first step is to determine the potential risk for the specific individual. So a very important history taking, medical history taking is very important. The majority of perimenopausal and recently menopausal women are good candidates for short-term hormone therapy for relief of the symptoms. For women with a history of breast cancer, coronary artery disease, a previous thromboembolic phenomena or stroke, or those with moderate or high risk of these complications, alternative to hormone therapy should be suggested. So this again, woman on fire while she's doing her work. How can she work? Now, managing moderate to severe hot flashes, MHT in a bit of detail. MHT either with estrogen alone following hysterectomy or both estrogen and progesterone in the presence of the uterus to avoid endometrial hyperplasia is recommended as the first line therapy, provided the woman is less than 60 years of age and does not have contraindication to HRT such as the past stroke or breast cancer or past thromboembolic phenomena or coronary artery disease, active liver disease, unexplained vaginal bleeding, known thrombophilic state, and active gallbladder disease. MHT benefits both the hot flashes and other symptoms of menopause, such as mood changes, sleep problems, vaginal atrophy, dyspareunia, and joint ache. So it not only benefits one, it benefits a lot of other spectrum of the problems. The route can be oral, transdermal, subcutaneous, implant, or intravaginal of the estrogen therapy and should be individualized in liaison with the patient. The efficacy of oral 17 beta estradiol 1 milligram daily, transdermal 17 beta estradiol 0.05 milligram daily, and conjugated estrogens 0.625 milligram daily is almost the same, with abolition of hot flashes in approximately 80% of the patients. As the transdermal formulations have lower risk of VTE and stroke, vaginal bleeding and breast tenderness, these may be used as the initial line of treatment. Start with 0.025 milligrams. So start with a lower dose. You start with 0.025 milligram estradiol transdermal preparation or oral estrogen 0.5 milligram estradiol daily. If required, the dose is increased at the monthly intervals to 0.05 milligram transdermal estradiol or 1 milligram oral of estradiol. For severe hot flashes, 0.05 milligram transdermal estradiol can be used from the beginning. Transdermal preparations avoid the hepatic, the metabolism route. The transdermal preparation is also preferred in women on thyroid hormone replacement. So this is a very important point. The patients taking thyroid hormone replacement therapy, transdermal preparation is the treatment of choice, as oral estrogens increase thyroid binding globulins, thereby decreasing the amount of free thyroxine. So these are the various routes we have already said. Then coming to the patients who have an intact uterus. Women with intact uterus need progesterone along with estrogens to prevent endometrial hyperplasia. Include natural micronized progesterone 200 milligram daily for the last 12 days of the cycle in the pre and the perimenopausal women. For women intolerant to cyclical progesterone therapy due to mood swings and bloating, the daily therapy may be better. For women intolerant to oral progesterone therapy, we can also institute a low-dose levonorgestrel releasing IUCD or Mirena, and this is also a very good modality for women who are intolerant to oral progesterone. For women without a uterus, estrogen alone is the treatment of choice. In USA, we have the conjugated equine estrogen 0.45 milligram in combination with basidoxepine 20 milligram, which is a SERM, is available for women who cannot tolerate estrogen or progesterone therapy. This is a very good combination. MHT is used for a maximum duration of 5 years or up to 60 years of age. It can be stopped in 40 to 50% of women within 1 year once they feel better, and 65 to 75% women within 2 years of the treatment. Once a decision to stop the MHT is taken, taper the drugs over 3 to 6 months. Do not stop it abruptly. For women who develop recurrence of severe hot flashes, more gradual taper can be undertaken. It can be tapered over a period of 6 months to 1 year. And low-dose OCPs containing 20 microgram of ethinyl estradiol may be used instead of HMT in the perimenopausal women who are in the age group of 40 to 50 years who desire contraception and have heavy bleeding. So once the woman reaches the age of 50 to 51 years, then you can consider either complete stoppage of the OCP or replace it with a low-dose MHT. The routine mammography and breast examinations are recommended for every patient who's on HMT. Now, coming to a very special case, if you have a lady 65 years plus or 70 plus and she comes to you with hot flashes, and they can be, and she's the person who will never talk about this problem, what do we do? So for these special class of women who develop recurrence of hot flashes, non-hormonal treatment options are used first, followed by extended HMT, that is beyond 60 to 65 years of age, low dose, short interval, if no other treatment is working for her. So one point I wanted to take from here in the slide is, in a case of premature ovarian insufficiency, what do you do? That lady, younger than 40 years of age, surgical menopause, or whatever the cause is. So lifestyle modifications, calcium, vitamin D, and MHT in the full dose till the natural age of menopause. Now, one word about Timolol. I always say it's a very nice drug. It can be used only in the post-menopausal women, 2.5 milligram daily, orally, and has very good effect upon the hot flashes or the vasomotor symptoms. The side effects are nausea, breakthrough bleeding, breast tenderness, and the reduction in HDL levels are there. So lipid profile has to be really monitored well once the patient is on this
I'm
drug.
sorry to interrupt. Just 1 minute left now.
Yeah. So now that was the most important part. Coming to SSRI, SNRI, these are the drugs that can be used. The only important one here is paroxetine, 10 to 25 milligram daily. That is the first choice. Clonidine, not very much used because of the side effects. Then gabapentin is important because it is used for patients, drug of choice for night sweats. So a dose is 900 milligram per day. And this is used only for night sweat patients. So these are the patients sweating at night. And coming to non-prescription therapies, we know weight loss, regular exercise, cessation of smoking. On these all factors are very important. They have their own role. Lady having hot flashes, even the babies in the house are sad. So complementary medicine, just one line about them. All these breathing exercises are very important. Yoga, Ayurveda, acupressure, acupuncture, Tai Chi, naturopathy, aromatherapy, all have their place. But there's not too much of work done on them. Vitamin E, yes, a few studies have shown that a very minor, effect it may have benefit for these patients if given in the dose of 800 international unit per day. Black cohosh, the NAMS Society says that it has marginal benefit upon the patients with hot flashes. Then you have red clover, ginseng, phytoestrogens. These are the 4 types of phytoestrogens found mainly in all the legumes, red clover, lentils, chickpeas, sprouted legumes, red and yellow vegetables, citrus fruits, most cereals and vegetables. So all these phytoestrogens, we normally take in our diet, but the most of the trials in these review were very small as far as phytoestrogens are concerned and of very short duration and a poor quality. So some trials did find that they have a beneficial effect, but the more research needs to be done on that. So herbal medicines, these are some trials done on these herbal medicines. Soy protein, 11 studies worth the name were there, and the effect is very variable. Black cohosh, 4 studies, modest effect. Rest of the these red clover and all these things did not have much effect on the hot flashes. So I would always say that hot flashes, not only it's the medical treatment, it's your whole attitude towards life actually, which determines how you face these problems. So whatever you love to do in your life, you love to dance, you love to exercise, you love to sing, please go ahead, because your mind needs to be diverted from your problems. And once the mind is diverted, most of us medical professionals, we didn't even know when our menopause came and went, because we have always been so busy in our work that we never really felt the problem. So I think when you are not doing anything, you feel the problems more. Do exercise, enjoy your midlife as much as you can. So a few take-home messages: hot flashes may not be a major health hazard, but they compromise your quality of life majorly. Hot flashes is one of the indications for short-term MHT. If symptoms necessitate longer therapy, alternative therapies can be taken into account. Lifestyle management has a definite role to play in all these problems. MHT to be started after proper counseling of the patient and explaining the risk and benefit profile to her. Hot flashes is an excellent opportunity to initiate preventive health services in the aging population, of which our population has no idea of preventive health, so it can be introduced. My most favorite motto of the Indian Menopause Society was fit at 40, strong at 60, and independent at 80. I always take my inspiration from this, motto. And menopausal clinics, please start menopausal clinics so that we can give benefit to these patients and give them some direction in life. They are actually absolutely without a direction. Thank you so much.